So welcome everyone. I'm so glad to see everybody here, and I'm so happy that Dr. Jeffrey Ritter has accepted to talk to us about osteoporosis today. He is an amazing, you can't see him, he's invisible right now, but he's an amazing rheumatologist, my favorite rheumatologist, and he's co-director of the Center for Arthritis and Rheumatic Diseases in South Miami. I didn't know this before, but I'm totally impressed that he attended Yale University and George Washington Medical School, where he graduated with honors. He did his internship and residency in internal medicine at St. Luke's Roosevelt Hospital in New York City and had a rheumatology fellowship at Georgetown. He practiced rheumatology in Washington, D.C. until he came to Florida to join the Center for Arthritis and Rheumatic Diseases. Thank you, and everybody welcome Dr. Ritter. Okay. Yes, they're all muted, but they believe it. Yeah, right.
Thank you.
Thank you.
Well, thank you for all attending. It's good to be back. So what I'm going to talk about today is about bone strength, bone health, which is very, very important for women, all women, and especially women with breast cancer who are on medications that will decrease bone mass density and predispose towards fractures. So let's start with about osteoporosis. I mean, osteoporosis obviously is more common in women. Some men do get it, and some men do get breast cancer. Now, we talk about bone strength, and your maximum bone density occurs at age 30. Estrogen preserves your bone. When you go through menopause, you lose the effect of estrogen on your bone and you start losing bone very quickly. For women with breast cancer, on certain medications, such as the aromatase inhibitors, such as Femara, Arimidex, they actually further lower your estrogen effect, which then makes you more at risk for losing bone density. So what do we mean by bone density? Density is the strength. It's volume over mass. So let me show you. So I liken it to a piece of cheese. So let's show you in my left hand system. Oh, there it is. That's what normal bone looks like. Think about a piece of Swiss cheese with very strong struts in between. Now, osteoporosis is like a piece of Swiss cheese that the mouse has gotten into, and this is what it looks like. So you can see the difference is that the holes are much larger and the struts in between are much thinner. Again, let me give you another example. If you had a table and you had spindly legs and you had another table with very heavy legs and you start putting cinder blocks on that, or you jump on it, which table is going to break? The one with the spindly legs, the one that has less thick struts. There we go. Okay, the one on my right hand. So the reason we treat osteoporosis is to reduce the risk of fracturing. About 10 million women over the age of 50 in this country have osteoporosis. About 1.5 women per year will experience a osteoporotic fracture. Another 34 million women are more at risk for osteoporosis and complications. We treat osteoporosis because you can reduce the risk of fracture. We don't treat it as a concept. We treat it because there's a direct correlation between osteoporosis and osteoporotic fractures. And there are certain complications from osteoporotic fractures that are very important, which drive us to treat. It's all about risk versus benefit. So at age, we define osteoporosis. You know, you've all seen these bone densities. I have it right up in here, the nice colorful charts, and people say, oh, look, I'm in the red zone, I'm in the yellow zone, I'm in the green zone. It doesn't really, don't look at the picture. All you know is 3 simple numbers. And you could be a junior rheumatologist who specializes in osteoporosis. We look at T-scores. If your T-score is -1 or better, it's normal bone. If your T-score is -2.5 or worse, it's osteoporosis. Additionally, people look and go, oh, it's my neck, it's my back, it's my, no. So when you look at these bone densities, people say, oh, what's my neck? The neck is actually the hip. And it's very important to measure your wrist too. So things that may alter your bone density reading is if you have osteoarthritis, if you have osteoporosis, it may falsely change the results. And that's why you really need to go to a specialist in osteoporosis to look at the scans, to decide whether it's accurate scan. A lot of times the primaries will get the bone densities, they'll say there's a 20% bone loss, and unless there's something very bad going on, you're not gonna have a 20% bone loss in a year. So that's, and I always look at the bone density. If it's done at Baptist, my patient works in records and she'll send me the copy with all the data and all the graphs. It's very important to look at it and compare it to the previous ones. And also to know that there's, in this town, there are some bone densities which are hologic, some that are lunar, which can make a difference in terms of comparing. So understand, if your bone density is minus 2.5 or worse, you have osteoporosis. Now, if it's minus 1 or better, it's normal. But there's a gray zone in between. You have osteopenia. If you have osteoporosis, there's a 50% chance of fracturing in your lifetime. For every one below minus 1 on your bone density, you increase your fracture risk by 1.5. So at minus 2.5, your fracture risk is doubled. As you go further, the fracture risk increases. Also, age plays a big role in this and determining whether you get treated or not. As you get older, your risk of fracture for the same T-score or degree of osteoporosis worsens. So a person that's 75 has an increased risk of fracturing at the same T-score as somebody who is 60. Very important. So I might not treat somebody at 55 or 60, but I certainly might treat somebody at 50, 75, even though they have osteopenia. So why do we treat? What's the issue about fractures? Oh, I fractured my wrist, I fractured my hip. Not a big deal. Well, there is a big deal. As you get older, you fracture your hip. The data is varies. Within a year or two, there's a 10 to 20% chance of dying for a number of reasons. And I'm sure people out there have parents who fractured their hip who have passed away. That's significant. There's also an even higher risk as you in the older population that you may not get independent living obtained again. Now, there was a study that said, would you rather be in a nursing home or dead? And most people said dead. And that's important following a fracture in terms of regaining your independence. If you have a vertebral fracture, that has implications as well. You all seen the pictures, I don't want to have a dowager's hump, I don't want to be bent over. Well, if you have enough fractures, you're going to be bent over because, in a lot of cases, because you fracture from the front more so than the back. So it doesn't look good. You can have chronic pain. Also, your belly may stand out, your posture may be off, and your walking may be off. So the reason you retreat is to reduce the risk of fractures, which we can do with medication because of the complications of osteoporosis fractures. So, right, I am talking to a special group of people with breast cancer. The medications that you're on, or many of you are on, the aromatase inhibitors, like I mentioned before, Arimidex, Femara, they reduce estrogen further, making you more at risk for fractures. So as a group, we want to aggressively treat to reduce fractures in the future because of your increased risk. Grace and the other oncologists will speak to the fact that people are on these aromatase inhibitors longer and longer periods of time, and you continue to lose bone mass over time. When you go through menopause, you initially lose bone mass 1 to 2% over 6 to 12 years, and then you start losing 1% per year. So in addition to this special group who are on these aromatase inhibitors to prevent recurrence of or reduce the risk of recurrence of breast cancer, there are other risk factors. So number one, when I see a patient, I'm assessing their other risks. Very important. So if you had a parent or a grandparent who had a hip fracture, you are at increased risk. That's actually the most significant. What other things in your life can increase the risk? Certain seizure medications may increase the risk of osteoporosis and fractures. Have on oral or inhaled steroids for lengthy periods of time. People with celiac disease, chronic diarrhea may be an increased risk for osteoporosis and fractures. Patients who have hyperparathyroidism are at increased risk for bone loss. That's not thyroid disease, it's hyperparathyroid. But if you have hypothyroidism and you're taking thyroid medication and your primary is not monitoring well your response, if you're taking too much, then you're going to start losing more bone than you should. Now, sometimes the primary says it's okay to have a little too much, but in your bone health, it's really not. Also, smoking, very bad for everything in your bones. More than 3 alcoholic beverages a day, also not good. All right, so those are risk factors that everybody should be assessed for when we're assessing bone health and osteoporosis. So if you have more risk factors, then we may be more likely to treat if you have osteopenia versus osteoporosis. Now, what can you do before we talk about medications to help with your bone health? Well, calcium. Now, there are a lot of primaries that say you shouldn't take calcium because it's not good for your heart or your brain, because it increases the risk of cardiovascular disease. And there was some studies about 12 years ago, 10 years ago, that suggested this was true. But the most recent data suggests or indicates there is no increased risk of cardiovascular disease with calcium. And that's very important. So unless you have a history of kidney stones in which you would reduce the amount of calcium you take, then you should take calcium. If you don't, bones, you've got to make bone. You need bricks and you need the mortar. You need medication and you need the cement. So without calcium and vitamin D, you're not going to make good, healthy bone. And that's been documented. Recommendation across the board is 1,200 milligrams of calcium, diet plus supplements. Now, I can't keep in track how much calcium's in a glass. And look, it's about 100, an ounce is about 140 milligrams. You have kale, you have cheese, about 190 degrees. That's how it's hot in here. About 190 milligrams in yogurt. But combined, you want about 1,200. You also want vitamin D. You need vitamin D. And you would like a level of vitamin level about, I'd say in the 30s and 40s, again, makes for better bone. Now, you can't take too much vitamin D because you don't want it in the 80s or 100s. It's not good for you. And also the recommendations are, you really want to keep the amount of vitamin D between 4,000 and 5,000 units a day, vitamin D3, not more. You can do less if your vitamin D level is good, but not more generally, because there can be there's some studies suggest that more may actually increase the risk of fracture. And a lot of people are taking 10,000 units daily because they think more is better. It's not better. Additionally, in terms of going back to the calcium, a lot of people can't take calcium. I'm constipated. It bothers my stomach. And you know what? If that's the case, it's the case. So more dietary calcium. Calcium citrate versus calcium carbonate is better absorbed and less constipating. That would be Citracal. So people say I'm more constipated, I have upset stomach. Calcium citrate. Additionally, with the calcium and vitamin D, you want to take it as every day. Weight-bearing exercise, so important. You can take calcium to your piece of chalk. You can take vitamin D to you have liver inflammation. However, you're not going to reduce your fracture risk. Why do we treat? We're reducing your fracture risk. You will slow down the bone loss, but we won't treat your osteoporosis. And the goal of treatment is to reduce your fracture risk. Weight-bearing exercise, very important as well. Again, you're not going to reduce your fracture risk, but you're going to reduce your risk of falling. You're going to reduce the progression of osteoporosis. As we get older, our balance is not as good for multiple reasons. We have, your vision is not as good. Your balance sensor is not as good. You may have arthritis. All those things conspire to make you more at risk for falling. Get up on a stepladder, see how sure you feel, go up and down stairs, stand on one leg. You'll get a sense. And also when we take into account what we're going to treat, is this person have macular degeneration? Do they have a peripheral neuropathy? They have arthritis in their hips and knees, all taken in to the calculation whether we treat or not. So again, we've established, and remember, bone is alive. I feel like Morse code, it's alive. Bone is alive. You have bone osteoblasts that build bone. You have osteoclasts that break down bone. B for blast, build, C for class, chew up bones all the time. It's going on continuously. So we can do two things to increase your bone density and reduce your risk of fracture. We can stimulate the bone formation with by stimulating the bone osteoblast, or we can reduce bone breakdown so you have a relative formation. Either way, you will reduce fracture risk in the vast majority of cases. All right, so there are several medications that may reduce fracture risk. And they've gotten a bad rap in the last 10, 15 years. You have the oral medications, which is Fosamax, Alendronate, Boniva, Actonel, Residronate, and the intravenous form, which is we call Reclass, and the oncologist Zometa. Then you have Prolia, which is an injection twice a year. There are other medications called Tymlos and Forteo, which stimulate bone formation. And in the last 3 years, they've introduced something called Evinity, which again is an injection which stimulates bone formation. So let's take the two most common medications that we use for osteoporosis. That is Alendronate, Fosamax, Boniva, and Prolia. Both those medications, and across the board, let me say, no matter what we use, be it Fosamax, Prolia, Evinity, or Tymlos, they only reduce fracture risk in your hip between 40 and 50%, no matter what you use. However, there's a big difference in fracture risk reduction in your spine, depending on what you use. So now, when you go to a restaurant, you might want the lobster, but you can only afford the hamburger. And so this is what happens with medication. If I was king, everybody would get Tymlos or Prolia. Since I'm not the head of, Medicare, I can't do that. But they all reduce fracture risk to a certain degree. So first, let's talk about the medications, the oral medications, and the Reclass as well. So again, they reduce fracture risk in your spine by about 60%. And it's a pill. It could be once a month, or it could be once a week. The most important thing is that you take it correctly. I don't know how many people I see, and I don't talk slowly, but I try to talk slowly when I tell people this. If you don't take it correctly, if you don't take it every week or every month, the efficacy goes down by 60%. So you've wasted a year, you've wasted 2 years. You forget. So I tell people, you take it first thing in the morning with water, nothing in your stomach before. And that includes your thyroid medication, which you are told to take on an empty stomach. You take it with water, not tea, not juice, not coffee, not chocolate, and you wait a half hour to an hour before you put anything in your stomach or you take any additional pills. Very important. So what are the side effects of those medications? And you've been told by your primaries you're going to take it for 3 to 5 years, otherwise you're going to have X happen to you. Yes, but it's all risk versus benefit. If I have a patient high risk, if I have a patient who has osteoporosis of their hip, the benefit of continuing outweighs the risk. So what's the risk? And this is true for the tablets, Fosamax and Actonel and Boniva, the Reclass intravenous, and for Prolia, which I'll talk about in a moment. And these risks are exactly the same. So there's a risk where you can actually spontaneously fracture your thigh bone or hip. But that number is 0.8 out of 10,000. And for those math whizzes out there, and I ask my son, it's 0.008%. What's your risk of fracture in your lifetime? 50%. If you have a spine, if you start to have pain in your thigh or hip, it's not a fracture, you come, we evaluate to make sure it's not a atypical fracture. I've had some in the past, I really haven't seen any recently. Now, what freaks people out even more is, oh, my teeth are going to fall out. Osteonecrosis of the jaw. They go to the dentist says, oh, your teeth are going to fall out. Don't take this medication. Well, I've seen enough osteonecrosis of the jaw. A hip fracture is worse, a wrist fracture is worse, and a spinal fracture is worse. So most endocrinologists and rheumatologists say it's a risk, but the risk is outweighed by the benefit. So what is that risk? It's 5 out of 10,000. What's the number? 0.05%. If you need a dental extraction or implant, that risk goes up. Because that's about, after reviewing the dental literature, about 5%. In my experience, and I've seen enough of this, usually it heals spontaneously after 6+ months. Maybe they have to use some antibiotics. I've seen a couple of people who need a scraping, and your dentist will freak out. They'll send me a letter, please, clear the patient with the procedure. And I say, I've always discussed it with the patient. If they have an abscess, they need it, go ahead and do it. Because of my patients, I've explained that. Again, that risk is a lot less than you fracturing your spine, your wrist, your hip, and the complication of such. And the 3 to 5 rule has to be assessed by your endocrinologist or your rheumatologist, not your primary, to decide whether the benefit of continuing outweighs the risk. Also, patients with bad reflux or stomachs. So the medication can also cause esophagitis, irritation of the stomach, so they may not be a candidate for it. It can cause aching all over like the flu. The other thing there is an intravenous form called Reclass or Zometa that not only helps the bones, but actually does reduce estrogen receptor positive reoccurrence. And that's part of the armamentarium that the oncologists use. So that's also an option. It's a twofer. BOGA helps your bones, may help your breast cancer as well. So that's Reclass and intravenous form of the Fosamax or Actina. Now we have Prolia. Everybody wants Prolia. It's all advertised. People see, walk around, you're going to fall, you're going to fracture. And then they hear, oh, you're going to be on Prolia for life. I don't want to start it. Well, that's not true. So Prolia, just like Fosamax, slows down the breakdown, but it does it differently. It's like a switch. It turns off the cells that break it down. And then after 6 months, they start to be active again. The Prolia, remember I said the fracture reduction with the Fosamax and the pills, it's about 60%. With Prolia, it's about 70%. Better number. Remember, hip's about the same. The risk of fracturing your thigh bone or hip is exactly the same as the tablets. The risk of the osteonecrosis is exactly the same. The Prolia has a slight increased risk of infections and rashes. And, I can count on one hand that I've seen that. And I always ask the patient, do you have an increased risk? Do you have urinary tract infections all the time? Do you have chronic bronchitis? Do you have some sort of immune deficiency? Now, we have patients with rheumatoid arthritis and lupus that are immunosuppressed on their medications, and we still use it. And we don't see an increased risk of infections. It's an injection twice a year, and you see benefit. The fracture risk reduction does continue, and they've just recently came out data going on 10 years. So you can continue it for 10 years. We don't have data beyond 10 years, but you'd still reduce fracture risk. Now, can you get off of it? I have patients that their bone density after several years can be 3, 4, 6, 8, get better. And I will then stop it. But when I stop it, very importantly, you have to give something to hold on to the bone that you've improved. Because remember I said, it's like a switch. Once that switch is turned off, you start losing bone very quickly, and there may be an increased risk of fractures. So what we do is when we stop the Prolia, we give the Reclass. And that cements in the improvement for at least a couple of years. That's Prolia. Now, why is Prolia a problem in some patients? Because it's more expensive. It's about $1,250 twice a year. The Fosamax is probably about $4 a month, or maybe $12. Reclass was amazed about $150 or $100 for a year. And a lot of the insurances require that you go through one before you get to the other, because insurance is not really there to keep you healthy, but to make a profit. So like I said, if I was king, I'd go with the ones more expensive. So that's what we have with Prolia. It's a great drug in terms of fracture risk reduction, even better than the Fosamax. But again, it may be a financial imperative. And a lot of the Medicare Advantage programs like AvMed or some of the other ones, they only pay 80%, but then your cost would be $250 a year or twice a year. And that can be a lot of money for people on a fixed income. And we have to respect that. And so we'll find things that reduce your fracture risk as well. Let's go to the Tymlos and Forteo. Tymlos and Forteo build bone. They stimulate bone formation. But for a lot of you, you can't take that because one of the contraindications in terms of taking those medications is having had a radiation therapy. So you've had radiation therapy, you cannot do Forteo and Tymlos. So they stimulate bone formation. Why are they better? Again, in the spine, they reduce fracture in your spine by 85%, 85%, significant. And you start, so go back to Prolia for a second. You start seeing fracture risk reduction the first year of taking Prolia by 60%. By year 2, it's in that 70% range. And also within a year, you see fracture risk reduction in Tymlos and Forteo. So the problem with Tymlos and Forteo is that it's very expensive. It's anywhere from $1,800 to $2,500 dollars a month, depending what you use. And let me go back for a second. If you have a fracture, and that could be, let me go back for a second before I go there. What's a fragility fracture? If you fall from standing height and you fracture your shoulder, your wrist, your spine, your hip, your lower leg, you have osteoporosis if you're menopausal, regardless of your bone density. Very important. I forgot to say that. I don't know how people come in, oh, doc, I fractured my wrist 2 years ago, but I fell on a hard surface. Everybody has tile here. I said, nah. You have osteoporosis. We're going to treat you. And if you have a fracture, your risk of fracture in the next 2 years is very high, anywhere from 17% to 50%. So I forgot to say that. Very important. So again, if you fracture any of those spots that I mentioned and your bone density shows osteopenia, you need to get treated. I don't know how many people I see with hip fracture, and they come to me 2 years later and they've never been treated for osteoporosis. They're at high risk. Going back to Tymlos and Forteo. So they are injections you give yourself every day. It is easy. My mom, God rest her soul, she didn't take it until her friends were on it. And she had multiple fractures because she was smarter than me. She was a science teacher. So she never listened, but she was eventually on it. And my mom, she was in her late 80s and was doing it. It's so simple. I had a guy who had a stroke, was doing it with one hand. I had a blind person doing it. It seems horrible, but you don't feel it. It's really easy. So it stimulates bone formation. And the reason why you can't do it with radiation, because the Forteo, which came out 25 years ago, they did the studies, the rats they picked were predisposed towards bone cancer sarcoma. So they picked the wrong rat. The FDA said, okay, you picked the wrong rat, so we're going to let it you. It's going to be FDA approved, but you can only take it for 2 years. Now, in 25 years, we have never seen a signal, meaning there's no increased risk of osteosarcomas in humans. But what predisposes towards bone cancer and sarcomas? Radiation. Now, Tymlos doesn't even have that. They haven't found that risk, but still gets lumped into it. So if you have really bad osteoporosis and you've had fractures, or your T-scores are -3, 5, or 4, best medication you could possibly take. You only take it for 18 to 24 months. Everybody's going, oh yeah, that's a lot of months, but it goes by quickly. So best thing you can do, really beneficial if it's affordable and you can do the shots and you haven't had radiation. Lastly, there's Avidity, which came out in the last couple of years. Again, a bone builder. Everything is sort of serendipity and eureka. So there's a group of people who have high bone mass. And they studied this group and they found out what it is that gives them a high bone mass. And they were able to manufacture it. So it stimulates bone formation. So it's a much better metabolic way of building bone. It reduces the fracture risk, very similar to everything else. But it's a shot we do in the office once a month for 12 months. So sometimes if people are getting worse on their current regimen, we give them that and we go back to something else. Again, does have the risk of the osteonecrosis of the jaw, fractures of the thigh bone, and it does have a slight increase of cardiovascular disease, heart attacks and stroke. Now everybody's taking a deep breath going, oh, I don't want that. But the bottom line is, I'm not giving to somebody who has a heart attack or stroke. And the FDA said the risk is so small. If a woman had a heart attack the year before, you don't do it because they're at risk independently of having a heart attack the next year. But if you had a heart attack 2 years ago, no problem. Again, it's more of an emotional thing about heart attack and stroke, but it's very low risk. So we have 4 agents. Now, other people, there's the raloxifene, which is a hormones that it's a hormone they've taken, they've changed it. And so it does reduce fracture risk, but you're not going to be on Femara, Ramadex, and raloxifene. Raloxifene may be good, and it's very weak actor. So it only reduces the fractures in the spine by a very little amount and doesn't reduce fracture risk in the hip. So people will say, that's like a Hail Mary, something you can do, and it may help. But it's not something we use all the time. Maybe if osteopenia and you have a family history, a high family history of breast cancer, you may want to take that because it may reduce the risk of developing breast cancer. So that's raloxifene. Also hormones. Now, I'm not an OBGYN and I can't speak to the oncological risk of hormones, but recently, again, there's some data that suggests it may reduce fracture risk in the spine only, but a very small amount. But then you would have to have this discussion with your oncologist or your cardiologist because there is possibly some cardiovascular risk of blood clots, and the oncological risk as well. So yeah, data we think of it as not really helping much, but for people who have osteopenia, know the risk factors, it may be an option, especially if you have a lot of postmenopausal symptoms. A lot of people are on it. So again, osteoporosis is less dense bone, predisposing towards fracture, which is not a low risk, that has complications in terms of morbidity, morbidity, chronic pain, ending up in a nursing home, not walking right, mortality, which is not insignificant. And we can reduce that fracture risk significantly in your spine, anywhere from 60 to 85%, in your hip by 40 to 50%. And, take calcium and vitamin D and walk. So I think I've said everything I need to do. And if there are any questions, I'm happy to answer them.
Okay, so thank you so much, Dr. Ritter. That was really fabulous. A lot of good information. I have already switched the chat feature so you can speak directly to me. So if there's any questions, you can just type them in and I will read them out loud. We already have one question, which is there a time limit? Somebody said if they had radiation over 10 years ago, but then they develop osteoporosis, can they take the treatment you discussed?
They can't, no. Any history of radiation precludes the taking of Timlosa fortea because of that risk. Because that's an independent risk for sarcoma, osteosarcoma. No.
Okay. Next question. Are calcium supplements okay if you have macular degeneration?
There's no reason why you can't take it with macular degeneration.
Okay, I like this. Quick. All right. Somebody's asking if you could repeat the information about the vitamin D, the quantities that are necessary.
So let me also say, if you want to go to a site to figure out how much calcium is in your food, go to the National Osteoporosis Foundation. They have a list of all the foods and can tell you how much is in each: kale, nuts, whatever. So in terms of vitamin D, you'd like your levels in the 30 range, and 40 is actually good, but you don't really want to take 10,000 units daily. You don't want to take 50,000 units daily. It's too much. So between the rheumatology groups and the endocrinologists, it's between 4,000 and 5,000. There is one study, and it hasn't seen it again, that it may be an increased risk of fractures when you take more than 4,000 units daily, but I haven't seen that study actually repeated or corroborated. So that's why if you look at all the groups, it's usually 4,000 to 5,000 units daily. Vitamin D3.
Okay, thank you. Somebody's saying some centers do radius bone density. How does that compare with spine and hip?
Okay, so we have different types of bone. The radius is the rest. So if you have osteoarthritis in your spine, if you have scoliosis, it's not going to be a valid measure. If you have osteoarthritis, because that will it's a machine. The machine wants people to be perfect. That's the way they decided how to do the measurements. Also, the precision of a bone density is 3%, very important. So I get these referrals all the time. Bone density went down 3% or 4%. If you do a test 100 times, you're going to be up 3% or down 3% by a basis of precision machine. That said, if you have let's say you have no hips because you have had hip replacement, bad arthritis, scoliosis, we have different types of bone. In our spine, it's called trabecular bone. In our long bones, hips, legs, arms, we have cortical bone. So the wrist actually is a combination of the two. So we always measure the wrist because it gives us more information. So that's the radius. So in our office, we measure the radius as well as the spine and the hip. That gives us good information about your bone health. Some of the places don't do it. Sometimes they do it. Baptists may or may not do it, but I always get a wrist. And sometimes when people come to me with only a spine and a hip measurement, I will have them go see our technician and we'll do a wrist just to be complete.
Okay, thank you. Who would determine if you should be evaluated by a rheumatologist?
Well, that would be your primary. That may be so we get referrals from primaries, sometimes orthopedists, neurosurgeons, and OBGYNs. I mean, I think between us and the endocrinologist, we deal with bone health. So either of us, I think, are the best people to follow up, and that could be your primary. It depends how comfortable they feel about treating. And oftentimes we see when there are changes. So what do we do when there's a change? We don't tolerate the medication, or, which is not uncommon, the patient doesn't want to take it. And to say to be a good doctor, you got to be a good salesperson. You're giving people medication that have side effects. But I've seen enough fractures and it just hurts me it doesn't hurt me when people won't take their medication. They come in, I get a call, they're bent over when they come the next time, they're in the hospital, they want to know which surgeon to use for their hip fracture. So oftentimes it's to try to get people on medication because their primary OBGYN can't convince them. And generally we do a pretty good job. So it's usually, unless you're having a problem, you're not getting better or it's getting worse, that's when we see you.
Okay. I think that's it for our questions. Oh, I think Dr. Wang has one more.
So, in breast cancer, there's like a bell-shaped curve. So we also would like a vitamin D level that's just above 30 to decrease the risk of recurrence. There's studies that show that. I saw one piece of information where if they take the weekly dose, that's not probably good because you might get that bell-shaped curve because you're going to get too much of the vitamin D level.
People come in and I say, yeah, right. Really, all the societies recommend not taking the 50,000 units. I mean, I have some people that are on 50,000 twice a week because I can't get their vitamin D level above 17 to give them medication. But that's the exception rather than the rule. Right. But you really don't want to do that. You want a steady state. Absolutely.
Okay. So you feel that way also. That's great.
Absolutely.
Great.
Absolutely.
Now we're learning a lot more about vitamin D. You need vitamin D for your macrophages for COVID, and you need it for the bones. I need it for breast cancer. So it's really becoming more important. Yet, we're drawing it more and more.
Absolutely.
But the radius question is that I always see osteoporosis in the radius, but I don't see it in the spine or the hips. And I don't